My name is Annalyn Jensen. I'm one of the first year industrial hygiene students in the MSOH program. And today I'm going to talk a little bit about drugs, specifically anti-neoplastic drugs. So for those of you that don't know what an anti-neoplastic drug is, we're going to kick it back to Greece real quick. Anti means opposed or against you, and then neoplastic, neo meaning new, and plastic meaning changing, means new growth. So in short, anti-neoplastic drugs are drugs that are opposed to new growth. They're used in cancer treatment, and they're designed to kill or inhibit cells that are rapidly dividing. So some common examples of anti-neoplastic drugs include the following. They work by different methods, disrupting the cell cycle to inhibit new cell growth. And that can involve methylating, or not methylating, but alkylating your DNA, or acting as a hormone disruptor in other places in the cell cycle. So something that was well established by this article is that while there are well-established health effects for occupational exposure to anti-neoplastic drugs, we don't have as well-established exposure limits or exposure strategies. Some of the current monitoring strategies that are outlined in this article are genotoxicity biomarkers. The article doesn't do a good job of explaining exactly what that means, but it does explain that it's technically demanding. There isn't really a threshold effect for how many genotoxic biomarkers you have to have until you have a health effect. And it doesn't really provide useful information when you're trying to protect your employees. The second method that was reviewed was biologic monitoring. This usually happens through like urine analysis. It's listed as more reliable. Again, they don't give a reason why. It also explains that a large portion of the drugs that you ingest are metabolized, and usually when they're looking at what you've absorbed, they're looking at either the parent drug or some type of metabolite of that drug. And yet again, there's no established acceptable intake or dose. They also tried air monitoring because some methods of chemotherapy distribution involve aerosolization, but it's listed as a poor predictor for exposure. And this is because your primary exposure, occupational exposure to anti-neoplastic drugs, is through dermal uptake, right? And then additionally with surface sampling, admittedly this was done in 2017, but they've been experiencing increased technology, improved technology through sampling methods in how we sample for anti-neoplastic drugs and also how we analyze that sample and how we're able to get a little bit of detection for that. So this article ruled out genotoxicity biomarkers and it also ruled out air monitoring when it's analyzing the connection between occupational absorbed dose and your surface sampling. So to go into a little bit more detail, I've probably already said this, but surface swipe sampling measures contamination on work surfaces. So this can be anywhere from a computer that somebody's typing on to a IV pump that they're hooking up their chemotherapy agent to, as well as the actual biosafety cabinets that they do something called compounding in, and that's when I'm probably going to explain it wrong, so my apologies to the MDs, but that's when you're manipulating the drug that you're using to then later administer. So that can be changing the dose, the dilution of it in a substance. And then biological monitoring is measuring your absorbed dose, and in this case, they use urine. And yet again, it's important to emphasize that there are no consensus guidelines on which of these methods is best, how to interpret the results from each method, how they connect to each other, and what a safe level might be. So surface swipe sampling typically looks something like this. You have a template. It's usually 10 by 10, and that's supposed to represent the space in your palm, fun fact. And if you're buying a commercially available kit, you get a kind of, it's a swab. It's kind of like a thing you use to clean your ears. Anyways, that's not really important, but you take that swab, you wet the surface, and then you wipe it up. And that's what they're talking about when they're talking about surface swipe sampling. So I wanted to give that visual just in case you're unfamiliar. And then biologic monitoring is kind of like, I mean, we've all peed in a cup for work at some point. It's like that. And then they take something that I imagine is like a pool test strip, and then they dip it in your pee to see metabolites of drugs and if the actual drug is present. The article doesn't go much into how this actually works. It just mentions that it is done. So the purpose of this study was to review studies that measured both surface contamination and then absorbed dose. And after that, to determine whether the surface contamination results with how much was actually absorbed by a worker. And then after that, they wanted to assess methodological limitations. So they did this through a systematic literature review using two databases, PubMed and Web of Science. I'll mention the search methods later, but as far as inclusion criteria went, it had to talk about occupational wipe sampling, it had to talk about urine biologic monitoring, and then it said that they had to have greater than 3 person days. And it's defined later in the article, but I think that's referring to it had to actually have people that were this in the urine exposure. If the test was deemed as positive, then they had a term called person days if they were positive. So they had to have actual people that were exposed according to the urine monitoring. At the end of this, 23 studies were issued. So this is table 1 from the article, but it gives a little bit of a summary of their literature search results. And so as you see, using different search results gives you different PubMed results. But at the end, they only had 23 articles that they included. So in terms of the data items that they abstracted, or maybe that's the wrong word, the data items that they were looking at in each article, for wipe sampling, they looked at the summary statistics reported by the article. So like your mean contamination level and such. They noted the limit of detection and the limit of quantification for the method used in the article, because those vary across articles. And then they standardized all of the results to nanograms per centimeter cubed, so that way they could compare between articles. For the urine biomonitoring, they had to determine whether or not the article had results that were detectable above the limit of detection. And then they, as I said before, they classified the result as a positive person day if at least one of their urine samples was above this limit of detection. And then they had to treat platinum and they had to treat platinum and a different anti-neoplastic drug slightly differently, because the way that they monitor for it is they monitor the metabolite of the drug instead of the parent drug itself. So this article encountered a lot of methodological challenges, and this was primarily because the studies in question were answering different primary questions, right? This study was looking at trying to find the link between your surface contamination and your actual absorbed exposure. But a lot of the studies that it was looking at, they were looking at, are controls working if we implement a different type of ventilation, for example, or a different type of engineering device, like a closed system transfer device? Are we seeing decrease in contamination, and are we seeing decrease in absorbed dose? And so because the studies were looking for a different way to interpret their data, the way they collected their data didn't really lend itself to answering the question posed by the study. A lot of the studies also specifically mentioned that they weren't able to find a surface biologic exposure relationship, which is what this study was looking for. And also the results between studies weren't really poolable. It was hard to find a way to compare them in a way that made statistical sense. And then in terms of data reporting, the articles had different units that they used to report their data. And so that made it harder to compare, even though they were able to standardize. And there was also variable handling of non-detects. So in industrial hygiene, when you get a surface sampling result, or not just a surface sampling result, but if you get a sampling result in general, and you get a 0 value, or if it's below the limit of detection, there's different ways to handle your data. Some people treat it as a 0. Some people use this method where you use the limit of detection divided by the square root of 2 to help eliminate that bias, to not give yourself an underreporting. There's likely contamination there. We just weren't able to detect it. And then in terms of inconsistent data reporting, each sample also had a different, or each study had a different way of sampling. And I'll go into this more detail later. But that variation also introduced error. And then additionally, it was noted that personal protective equipment and work practices were significant confounders when we're thinking about the difference between surface level contamination and absorbed dose. Because theoretically, we want to see our gloves, we want to see our ventilation, we want to see our PPE working to protect our employees. And so this made it hard to really draw a connection between what you're dermally exposed to, what's dermally, or not, what surface contamination is there, and what you're actually absorbing. Additionally, the studies that were analyzed didn't have a regular reporting of how often people are actually adhering to their PPE practices. And that also functioned as a confounder. So this is figure one from the paper. But this is what they tried to do to show a correlation between detectable anti-neoplastic drugs in urine versus wipe sampling. So they transformed the data by taking the wipe sampling results, and I think because they're like log normal, they transformed it that way to be able to analyze it. And I don't know if this is just my limited statistical understanding, but I think it's hard to tell what kind of relationship exists if there is any, and maybe that's what it's telling us, that there is no relationship, and that's what they stated later on in the paper. But this is what they kind of came up with after all their data analysis. So if we go back to the purpose of this study, it reviewed studies that measured both surface contamination and biological monitoring. But it wasn't really able to evaluate whether or not this surface contamination really correlated with absorption. And I think it did go into detail about assessing methodologic limitations, but the article as a whole didn't do a good job of making a statement and then explaining why it made the statement. So yes on objective 1, no on objective 2, kind of on objective 3, so I'm going to count that as a win. So in terms of the wipe sampling techniques that were observed across all of these different studies, there's lots of variety. Cyclophosphamide was the most frequently sampled, and that's because it's pretty stable, I want to say, on surfaces, so it's easy to, or not easy, but it's easier to discount the idea of a drug being volatile on a surface and then the surface contamination not relating to what was actually there at the time. It makes it easier to sample for, is what I'm trying to say. There's also a variety of different surfaces that were sampled in each study, with the biosafety cabinet where the compounding actually occurs being the most common, and compounding being the handling of that anti-neoplastic drug. And then the amount of areas sampled was not consistent between the studies. So while commercial kits for anti-neoplastic drugs have a specific template that you can use to get the same surface area between studies or between samples, these studies weren't necessarily using commercially available kits. And as I said before, recovery efficiencies can vary a lot, and that has implications for exposure estimates. Urine sampling techniques, you either had a pooled 24-hour sample, you had multiple fractions over the 24 hours, so it depends on how often they are collecting your pretty much. And then some studies did not include the limit of detection or limit of quantification for the study, and that influences how you interpret data. And you also have inner variability between people about how they handle drug exposure and how they metabolite that. I just took this straight from the article to say they weren't really able to find what they wanted to find, and that's the language that they used to describe that. So there wasn't really an association that they were able to find that was statistically significant between surface and urine samples. And then in the discussion, it kind of covers what I said before, but they had to manipulate their data a lot to try to be able to get the data to a point where they could analyze what they wanted to analyze. And I think that was a major limitation in being able to analyze and get what they wanted out of the data. So this brings me to discussion. Any questions before I start with my discussion questions?
I had 2 questions, but 1 comment, and I wanted to thank you for telling us what an AD is. I had to Google that. I had no clue. And but thank you for starting off with that. That was very good. 1, is there any reason to think that PPE like gloves is any less effective against ADs?
Less effective than what?
Or less effective for ADs than anything else?
I wouldn't know about that because that depends on like your permeation rates, how well it gets through. If your drug is, I don't know, corrosive in any sort of way. Maybe our MDs would know more about this.
Well, I was just curious, why study it unless there was something different about the AD through the different glove barriers?
Yeah. So are you asking why surface sampling is important?
No, why PPE was included.
Oh, okay. So if we're trying to think about, okay, let's say that this is my contaminated surface, right?
Yes.
And I am dealing with an anti-neoplastic or wait, no, this is a bad way to say it.
Well, let me ask you a different way. Is there any reason to believe that the PPE question could not be answered by adherence? So if you made everyone wear gloves, would the problem go away?
I think that it would definitely help. If you're wearing gloves, that's a barrier in your exposure, right? If I'm primarily worried about touching something that's contaminated and then uptaking it into my body, then wearing a glove would stop that.
Yeah, and
Right?
I'm saying it sounds like, to me, it sounds like a binary event. If you
You're
wear your
either wearing
gloves,
it or
it's not gonna happen. So just push.
So here's the problem though. Let's say I'm wearing gloves over here dealing with this, but then I go over to my computer and I type something. I'm not really worried about exposure because I'm wearing gloves, right? But then I take my gloves off and I throw them in the trash, right? And I go to do something else. And because I'm not dealing with an antineoplastic drug or a patient, I'm not worried about exposure. But then I come back over to my computer and I'm typing and voila, I get exposed because this area is now contaminated, but I don't think it's contaminated. Does that make any sense?
Yeah, it does, but that sounds like a policy issue, a
Oh, yeah.
laboratory policy issue.
Yeah.
Okay,
It's a
so
policy issue.
would it enforcement and adherence eliminate that?
I think enforcement and adherence would or it would help with that, but I think what's more important is for people to realize that their areas are contaminated, and that's what surface sampling helps you prove, I guess. You know, if I don't think that my keyboard is contaminated, but I have wipe sampling that has been done that proves, like visually to me as a worker, that, oh, there are things that I'm not considering when I'm,
But again, lab policy would probably
Yeah.
take care of that. So it would be a question of adherence, I guess.
yeah, I guess it's a question of adherence and what you can do to improve adherence, improve like motivation to adhere.
Let me ask
Okay.
another question. I'm sorry. Thank you. It's okay, with the rise of AI, it's easier to do searches and everything, right? And look at papers. So is everyone just doing research on other people's research?
I don't know. That would
Because
be
I'm seeing a lot of literature reviews. So I could know nothing about the subject. So could I Google AD drugs and just generate all this? It's a philosophical question, and I'm not. But maybe this is a question of the class.
Yeah.
Are we doing research on other people's research?
For sure.
Yeah.
There's, they call them meta-analyses,
Yeah, I know.
right?
I'm
Yeah.
seeing a lot of them.
Yeah, well, there are people in various disciplines who kind of specialize in meta-analysis because what happens is they get cited a lot too.
Yeah.
Because it's a summarization of what we know. Part of the problem though is there hasn't historically been quality control on them. And I've seen meta-analyses that have been published with like 5 studies. And it's like, that's it?
Yeah.
And maybe that's all there is, and that's fine.
Yeah.
But it also just kind of you need to recognize that not all meta-analyses are created equal. Not everyone that does them is reporting. You know, sometimes the reporting has an agenda associated with it, right? They're reviewing it from their own biases, which everyone has them, right? And so it's just you got to be a good consumer of research that's been, you know, secondhand summarized, right? And so I think there's a lot more of that than there ever used to be, because I don't remember there being meta-analyses.
It's
I
so
remember
easy
reading some
to
of the
do
first
that.
meta-analyses and it was like, oh, this is kind of neat, and now they're everywhere.
Yeah.
So,
Okay.
yeah, Ryan.
Yeah, I'm interested in backing up the topic a little bit, because there was discussion about the worker and their exposures and use of PPE. But how are these drugs administered, and how are surfaces ever being contaminated? You know, are they injectable drugs? And so I'm interested more in the upstream, you know, if we have clinicians here, about how on earth a surface could get contaminated with a dangerous drug. Is there something with the administration that is allowing that to happen that I don't know?
And my thought, I was thinking that too, is what about in anesthesiology where you have fentanyl being used? You know, how is that being administered? How can it be released?
Yeah. So how is the drug being contained in its administration? And I don't know very much about that. So
I mean, if it's IV, there's usually a protocol, right? But even when you pull out an IV, you know, there's a possibility of dripping information there. Some patients are actually anti-neoplastic, like their sweat might be, for example. So,
It's like
their
they
urine
have
is,
to use separate bathrooms, right?
yeah, and you know, their urine is you know, potentially toxic, so that has to be treated like to toxic waste, so they're treated differently.
So there's potential for behavior in and around like the disposal bins
Sure.
and the sanitation, environmental health service workers. You know, so if they're cleaning up, they could distribute the drugs onto surfaces.
Particularly if they're not aware of it.
Yeah.
Were janitorial people included as healthcare workers?
You know, I'm not sure. I'd have to go back to the
Question.
study.
Yeah.
I think it was typically talking about the healthcare, the people who actually were involved in patient care, involved in the compounding, because they were more focused on like the compounding aspect.
But we're doing wipe samples and bathrooms, you know, could be.
Oh, for sure. I think that's definitely something studies should include, right? Yeah.
Anyway, thank you.
I thought you did a great job for all of us non-IHers.
Yeah.
Thank you for that. My question, I guess, is do you feel like the biggest problem with this paper is that they really wanted to conduct a study that they couldn't, so they looked into studies and then found out it's not that they were interested in anyways, I guess, because you talked about how so many of the studies didn't meet their qualifications.
So I think that was definitely a limitation of the paper. I think that maybe the fact that they weren't able to meet the objective of the paper wasn't necessarily a bad thing. I think it was able to prove that, hey, if we want to model a relationship between surface contamination and what people are actually exposed to, and raise the question of, you know, how do we interpret our wipe sampling? Is it an effective intervention in actually protecting our employees? I think that was a good question to raise. And also it was good to review literature and prove that there isn't really an answer out there. Does that answer your question?
Yeah.
Any other questions? I've prepared questions if you want me to go over that, or
Yeah, we have a few minutes, so if you have.
I guess a question for the class I wanted to ask was, it's on my second slide of questions. But in working as an occupational health professional, what are your guys' thoughts on evaluating a hazard? Let's say it's anti-neoplastic drugs, when there isn't a well-established limit out there. And I think maybe you could say that this is similar for maybe evaluating psychosocial risk factors. Maybe that's a similar thing where you don't really have a cut and dry, like this is a hazard and this isn't, or this is a hazardous level and this isn't, because people react differently, right? But what are your guys' thoughts on interpreting our evaluation of workplace situations when there isn't a clear established limit?
That is a perfect question because you are all going to be facing new hazards as you go out there. They're going to be new drugs. They're going to be new technologies. They're going to be new techniques. And you, all of you in here, the younger people, will have to decide, you know, what is safe, what is healthy. And what do you think might be a good approach?
Medicine. I was gonna jump in.
Yeah.
Medicine, we just treat it as a universal precaution, where you just assume if you don't know what it is, just assume it's as toxic as possible and try to avoid,
But that gets into Proposition 65 problem, doesn't it?
Mhm.
Because, this is a little hazard, this is really, but you lump them together.
Well, you need to educate people about what that means, though. I mean, a lot of people don't know where Prop 65 came from, California and all that, but when you educate them as they go into a medical related job, you explain what that means and what it's for. So, but
what?
But I don't want people touching the plastics. That's what I mean.
No, I mean, and Prop 65 doesn't include wine because the wine industry didn't want a Prop 65 label on
Yeah,
it.
but
Yeah.
you're the only person in this room, I'm guessing, who probably knows that. That's what I mean. Like,
What I'm saying is we
You have to convince
we
me.
just can't say bad. There are different levels of bad.
Yeah.
And all of you, I believe, are gonna have to use science, use your professional knowledge, but ultimately, ethically, you're going to have to decide what safe levels are, or acceptable levels are. And you're all gonna disagree with each other, but you're going to have to satisfy yourself that you're doing a good job.
Yeah, I guess my question when I was like, looking through all the stuff and listening to the presentation was whether they were comparing these exposures to any like health outcomes. Because I feel like if there was a study that did look at, these drugs and then that exposure rate on like your x-axis or something, and then whatever adverse health outcome on your y-axis, I think that would probably be a good starting point for like limitations, but you just said ethical and, you know.
That goes into a different way.
Well, for example, you might be in the future on a committee to look at what the appropriate exposure level is. And what I say is just because something is written down doesn't mean that it's right. And you are all as smart as anyone on those committees, and don't unquestionably take whatever is written. But ultimately, sometimes you'll have to make your own decisions and just make sure that you are doing it with pure motives.
Yeah. Going back to something Rachel said, I like the idea that maybe the answer lies in really empowering the worker and helping them understand their exposure. I don't know, I thought that was an interesting thing that Rachel brought up.
Yeah.
I don't know if we're at time yet.
Yes, we are.
Yeah.
Thank you very much.
Thank you very much. Ian, how many people we got online?
We have 20 people online.
Wow. You missed some good food, guys, just saying. And some good company. I mean, we got some good people.
Hello, everyone. My name is Matt Aiken. If you haven't met me yet, I am one of the residents in the occupational medicine residency here. And my article is Lower Extremity Injury Rates on Artificial Turf versus Natural Grass Surfaces in the National Football League during the 21 and 22 seasons. This feels topical since we are knee deep into the playoffs right now. We just wrapped up the divisional round, one of the best weekends in sports of the year, in my opinion. But a little bit more background as to maybe why I chose this article. Has anybody here ever watched their favorite team have a player suffer a devastating injury? Yes, everyone. Okay, great. I'm not the only one. For the last 8 seasons, one of my good friends has been an assistant coach for the Kansas City Chiefs, who did not make the playoffs this year. Very sad. But after they were already eliminated from playoff contention, their quarterback, Patrick Mahomes, tore his ACL. And so now, things are looking very bleak for the future. The good news is my buddy just got a different job, so we don't have to worry about that. But I also, I went to medical school in Wisconsin. So I thought, you know what, maybe I should be a Green Bay Packers fan. And right before the playoffs, arguably their best defensive player, Micah Parsons, also tore his ACL. And then they lost in the first round of the playoffs. And
So are you gonna sing on Wisconsin for us?
I might sing on Wisconsin if there's time at the end, just
Okay.
to fill some time. I really love their polka up there in Green Bay. But to kind of bring this around to be more relevant to our industries. So I mean, we look at football as a sport, but it is also a profession which deals with a lot of occupational hazards and clearly a lot of injuries that have far-reaching economic impacts. And as a prospective physician myself, hopefully a medical director or chief medical officer for a company, and I'm sure all of us will be in positions where we'll be working at companies that deal with high rates of injuries and differing exposures. And so I thought this is maybe like a simulation of working for a company who's dealing with high injury rates and doing an evaluation of maybe what's causing those. And this article decided that looking at the playing surface as a potential exposure could impact what these injuries are. So a little bit more background about the playing surfaces. I included a picture of Rice Eccles Stadium because I'm also a very big Utes fan. Fun fact, the first indoor college football game ever played was in 1964, featured Utah versus West Virginia in the Liberty Bowl, which Utah did win. That was essentially, they just put grass laid over concrete for that game. Sounds very uncomfortable. I don't know what the injury rates were for that, but I'm sure it was maybe higher than normal. But as far as NFL stadiums are concerned, the first turf was played on at the Houston Astrodome in 1966, and that actually was like carpet laid over asphalt. And then since then, there have been advances in turf design. One of the pushes was toward permeable elastomeric layers of recycled rubber, polyurethane, and mineral aggregate. And then recently, there's been a push towards these new infill surfaces. And as of the 2005 NFL season, all stadiums had these infill surfaces that use long polyethylene fibers filled, and then with the spaces between the fibers filled with rubber particles or sand. And that's actually what the University of Utah uses now as well for their artificial turf. If you've ever walked on turf or like seen players like crash, you can kind of see like the spray of those like rubber particles. It's like kind of interesting little like pieces of tire almost. But perhaps anecdotally, a lot of fans of football have noticed players who play on turf have a higher rate of season-ending injuries. I know I've maybe held that opinion as a Utes fan over the last few years, but also MetLife Stadium, where the New York Giants and Jets play, is on artificial turf, and that has been like notoriously dubbed a cursed field due to the high rates of season-ending injuries. And so the authors, they note that maybe they are observing more injuries on the artificial turf, and that existing studies show discrepancies where there isn't a difference or there is a difference. And they also note that several of these studies have been funded by companies that profit from artificial turf. So there's potential conflicts of interest there. And so they hypothesized that lower extremity injuries requiring surgical intervention would occur at a higher rate on artificial turf versus natural grass. And so they wanted to use this study to quantify the rates of those injuries. Sometimes if you see a player like running free on a field and they trip and fall, they're said to be caught by like the turf monster. And so that can also be like, summarizing their hypothesis is the turf monster real? This is part of my AI incorporation into my presentation. I had created an image of this turf monster.
Well done.
Gary.
Thank you. So as far as how they decided to design this study, they wanted to look at the 2021 and 2022 NFL seasons. And then they said that they were going to obtain lower extremity injury data for those seasons from publicly available records. So they went to ESPN.com and NFL.com to get injury summaries for the games played. And that's how they obtained their injury data. That included injury type, player position and age, playing surface, weeks missed due to injury, and whether the patient underwent minor or major surgery. And then they included all in-game lower extremity injuries, and they decided to exclude any upper extremity injuries and then also any preseason data. As far as what this study design, kind of what it fits, I believe the article described it as a descriptive epidemiologic study. When I was initially looking at this article and reading it, I thought this sounds like a retrospective cohort design, but the way they described their methods and analyzed the data, they really only looked at players who had injuries, and so players who had the outcome. So it looked like they were looking at the outcome first and then quantifying if they had a potential exposure. So in that regard, it seems more of a case control study. I decided to ask ChatGPT what the study design was, and Chat told me it was a retrospective observational cohort study. But I disagree, and as we get into the methods, maybe that can be a little bit more apparent, because I do think they started with their outcome and then looked at the exposure. where artificial turf was maybe their case and injuries on natural grass was a control. But for their methods, they did their statistical analysis with our software. They wanted to look at both injury incidence and severity. For their incidence, it was the ratio of number of injuries that occurred on grass and turf and the number of games played on those respective surfaces. They stratified injuries into 4 different categories of severity based on the number of games missed. So if somebody sustained a lower extremity injury, but then missed 0 weeks of games after that, that was like their most minor. The next category was missing 1 to 2 games. The next category was missing 3 to 6 games. And then if someone missed 6 or more, that was like their kind of severe category. And then they also plan on performing a multivariable log regression to adjust for different confounders with setting a p-value of less than 0.05 as being statistically significant. This is just a table that they included showing the different fields in the NFL. So as you can see, slightly more teams play on natural grass, 16 versus, well, I guess 16 stadiums versus 13 stadiums are played on artificial turf. But as you can see, a few of those stadiums are the homes of multiple teams. And then here's just another table that they included that showed some of their results. I'll kind of summarize these in the next few slides. I'll just be on here. But you can see they broke down the injuries by playing position. The mean age of those who were injured was 26 years with a big range of 20 to 38-year-old. And then here is kind of what they really found. So across those 2 seasons, there was a total of 718 lower extremity injuries, with the majority of those occurring on artificial turf. As you can see, 386 versus 332. They calculated their incidence as 1.42 injuries per game, a little bit higher than 1.22 on natural grass. And then in this bar graph, I don't really love how they presented it, but the light gray is artificial turf versus like the dark, maybe that's black, dark gray was natural grass. And then this is like by injury severity. So as you can see, as you move left to right on the graph, the light gray takes up a larger proportion, indicating that as injuries became more severe, had a higher association with artificial turf. Regarding severity, I included a slide for Rachel to help remind her of her time in the operating room. So for injuries requiring lower extremity surgery, there was a higher rate of those on artificial turf. That was 83 injuries versus 50 on natural grass. And then they calculated an odds ratio for season-ending injury to be 1.6 with a confidence interval of 1.28, 1.99. So they did find that that was statistically significant as well. And then with their bivariate modeling, and they didn't show any like graphics or charts from this data, so I'm kind of just like reading this straight from the article. So bivariate modeling showed that the history of previous injury as well as field type influenced the risk of surgery, which makes sense. Anytime we see a patient in clinic and we're evaluating the risk for a certain disease, if they have a history of that disease, we're more likely to assume that they either have it or will be at risk of developing it. But in their multivariate model, the odds of season-ending surgery were significantly higher on artificial turf, but weather, age, position, week, and history of previous injury were not significant influences on the odds of season-ending surgery. So when they adjust for kind of all of these multiple confounders, they found that artificial turf is like the only one significantly associated with odds of season-ending surgery. And then just for kind of fun information, the most common surgeries were for an ACL repair, followed by an Achilles repair, followed by like an ankle reduction for someone who broke an ankle. So what did the authors conclude? They said that injuries were more likely to occur on artificial turf. And not only that, severe injuries were more likely on artificial turf, and that synthetic surfaces should be a consideration in any discussions or thoughts about future injury prevention. For some strengths and weaknesses in this study. So I thought that including both incidence and severity of injury was a strength of the study rather than just looking at one or the other, because it gives you just a little bit more information to work with. You know, if there was a high rate of injuries, but they were just like ankle rolls that they didn't miss any games, then it wouldn't really be kind of lead to meaningful conclusions. And the fact that they performed a multivariable regression, adjusting for confounders, I think is a strength. Again, they didn't talk about it much in their discussion or put any graphics of that. As far as weaknesses are concerned, I think having data derived from the publicly available sources isn't a strong study. I know NFL probably has mandatory reporting of injuries, but the publicly available data, it's probably prone to error. When looking at season-ending surgeries or just surgeries in general, there's a lot of factors that go into deciding whether or not an athlete will proceed with surgery, and those decisions were unknown. So we don't learn a lot from that analysis. They did exclude preseason and practice injuries, where if you were really wanting to do a comprehensive analysis of injury rates, I mean, these players are required to play in preseason and injury and practices, and injuries do occur in those settings. And so accounting for that data, I think, would be smart. And then just the study design in general, it didn't appear to be a true prospective design to me. And I think that's a little bit of a weakness because you can't really assess for causation as well. And so I have just 2 discussion questions prepared. And then obviously, if anybody has any other questions, feel free to chime in. But for my first question is, how would you present this to a team owner or league management as like a cost benefit analysis if, you know, you were giving them info about whether or not to move towards natural grass versus artificial turf, or kind of, you know, what conclusions can you draw from this study?
I'd say if you hypothetically were going to spend $50 million on a really good D lineman, then have him blow his ACL and then have his team lose in the playoff, it would probably be beneficial to have the most protection for your investments. And so if you're going to be spending a ton of money on players, it's probably worth the extra money to maintain a grass field.
Totally.
So as someone who is very familiar with the Mercedes-Benz Stadium and followed an MLS team in it since it started, I can say that they don't care, because we actually had grass put into the stadium because European teams refused to play on turf.
Yeah.
So we had to put in grass into the stadium. They just put it over the turf. And then they took it out and they wouldn't let any of the MLS teams play on it because they're like, it's too expensive.
Yeah.
And I don't know if that was the season we had like 7 players get injured on the turf.
Wow.
But like, even when they put it in, they won't keep it even just for the next weekend of games. Like,
Yeah.
They don't care.
When you say that the European players didn't want to play on the turf, was that due to fears of injury, or was that?
I don't know. I know like when Zlatan came and played with LA Galaxy, it was kind of a big deal because he like straight up wouldn't go to games where they were playing on turf.
Yeah.
I don't know, like Messi definitely has, but there were rumors that he wasn't going to when he first joined Miami.
Yeah.
But like they definitely don't like it. And then like when the big teams come in, they make you put turf, or not turf, like actual grass into the stadium. Like they won't play on it.
Yeah, and I think that has more to do with the nature of soccer than anything
Yeah.
else, because turf,
Play
the ball moves differently on turf than it does on grass.
Yeah, and then there was like some controversy with like women's games because the national women's team was having to play on turf fields, whereas the men's team was only playing on grass fields.
Sure.
And that was kind of a big deal. So like the turf grass argument is very big in soccer.
Yeah.
Is that an enclosed stadium? Or
Ben's? Yes and no.
Okay, because that raises another
Because
question.
the top of it opens up.
Because the Cardinals they have a field on a rollers that goes outside and then get sun and then bring it back in. So it may not be available to a totally enclosed stadium.
Yeah. No, anecdotally, I can say that I get way more injured on turf.
Yeah.
But I played goalie for 4 years in high school, which meant that I was sliding around on it. And if I didn't wear leggings, I'd get second-degree burns on my legs from the turf. So like, there's definitely more than just ACL problems.
Yeah.
Like, I've got a lot of scars on my legs from turf, so I don't like it. But
Yeah, no, absolutely.
it's a very complicated question.
Absolutely. And it is a very complicated question because when you factor in the economics of it,
Yeah.
so you mentioned, so yes, you were spending a lot of money on your players as assets, and potentially you're losing out on economic benefit if they are injured and your team doesn't advance. But then you also have to factor in you're paying for their medical costs as well. But then the costs of maintaining natural grass and keeping that alive versus artificial turf, it's a lot cheaper to do artificial turf. But
Yeah, I was wondering if maybe I missed it, or if you found any information, or if the study included non-contact versus contact injuries. Because if you watch the replay on injuries, a lot of times you can tell if someone got rolled up on, or if it was he was just running and then he starts limping. You could obviously tell he stepped on it funny. Did
Yeah.
they like differentiate between that in the study at all?
they didn't differentiate that between that in the study. And kind of just thinking back to that first slide. So when Patrick Mahomes hurt his knee, it was totally like a contact injury, which playing surface would not affect that, right? Or theoretically wouldn't have affected that. And I'm fairly certain that Michael Parsons was maybe non-contact.
Mhm.
And so I think if you were designing a study, you would have to include both, just because you can't really say for certain whether a contact injury would be prevented or caused by playing surface. But I do think it would be interesting to look at non-contact and see if those rates increase with playing surface.
Yeah, I was gonna say like that exact same question, but just to expand on that, I think it's really hard to present this to team owners because of that reason. Like both of those pictures of like Mahomes and Parsons they happened on grass fields.
Yeah.
So that kind of goes against, wanting to go for or like it with the study design, it happens more on turf fields, but in those two cases, it happened on grass. So another thing I was going to say with this is I'd almost be interested to see if you're to do like a backwards approach and look at all the surgeries, which ones were non-contact, which ones were contact injuries. And when they look at the players or the positions that it also happened to, 127 of them were offensive linemen, where I feel like for the most part they're involved in the play, usually in run plays where they're getting hit from behind, and I feel like a lot of those lower extremity injuries can happen when they get hit low and they're not expecting it and they can't really do anything about it. So that's like another confounder that is probably hard to analyze in this type of study.
Totally. Yeah, I think position type is going to vary widely based on like the type of injury they are susceptible to. And I don't think they included that in their multivariate log regression. I'm trying to remember like all those variables. I don't think they adjusted for position.
Yes, I, two questions. One, and maybe I missed the classification. What was a season-ending injury? Like if I get a relatively minor injury, modest injury on the last day of the season, that is season ending, but
Yep.
What were the criteria?
Well, that's a very good question. So they classified, there was basically two different categories. It was like games missed, right? So if you had an injury on the last game of the season and you didn't miss any weeks after that, I think you would have fallen into their incidence category of like, the 0 to 1.
Okay.
But when they talked about season-ending injuries, I'm sure they included that as this was a season-ending injury. So Patrick Mahomes, he got hurt in the last game of the season.
But that would have ended the season
It would have
anyway.
ended the season regardless of when it happened. So they didn't really talk much about that in their discussion and methods.
Okay.
And so there's a lot of details that I think they didn't either think about or didn't choose to elaborate on.
In the second one, you said you disagreed with ChatGPT on its classification of the study.
Yeah.
Did you push back on it?
No,
You should.
I should have argued with it, I know.
No,
but-
please, if you disagree with something, push back hard if you have to. And you'll see how it behaves. And then you'll get a feel for what you can expect out of it. I encourage everyone to argue with it.
Yeah.
Really.
I find if you do correct it and say, actually, this is how I saw it, they're just going to affirm whatever you believe.
Yeah, I know.
So I kind of want to like get rid of that though, because I don't want it just to reaffirm what I've told it.
Yeah.
But
It,
At the same
when you
time,
ask
I
a
understand
question,
it
they
well,
say,
yeah.
man, that's an insightful question. Yeah, I'm proud of myself, right, for asking that. So play with it, push it, see what you can expect out of it.
Totally. Like that.
I know we're almost at time, but, and I don't know much about football, but, when thinking about injury prevention, does training on turf, like, kind of accustom the body, to move better and prevent injury down the road? And, like, do players who train on real grass have worse outcomes later on turf fields?
Yeah, that is a fascinating question. I know in the discussion, they talked about kind of the theory behind maybe why there's differing injury rates is because of the way like cleats release on turf versus grass. And I think that's another weakness of the study. Like, what if teams were practicing on turf and then playing on grass or vice versa? How that could be adjusted for, because if an athlete is trained on a specific surface and then plays on that surface, their body might be used to the biomechanics and kind of feedback from those surfaces and not be as prone to injury. So that's actually really, really great thought.
And that's going to happen as a player is in the season, regardless of what they have at home, they're going to see the other somewhere.
Yeah. Yeah. And I'm sure teams, you can approach it as, hey, we're going to be playing on both surfaces, so maybe we should train on both surfaces. Or maybe they'll say, if we're more prone to be injured on one surface, let's not practice on that so we can reduce our exposure to that. So
yeah,
kind of interesting thought.
It's true.
I think we are kind of running low on time. We don't really need to get into this discussion question, but kind of statistical versus practical significance. That's always something I try and think about in regards to medicine. You can do all sorts of statistical analyses and find something that is statistically significant, but will it make a difference for patients? They calculated their odds ratio of 1.6, which I think is practically significant potentially, but there's a lot of flaws in this design. But it's just always something to think about. If something is statistically significant, is it still meaningful and should it lead to change? But I think that's kind of all I have for you. Thank you for your questions and comments.
Thank you.